So here we have the first company, Stryker, that's going to show us a little bit of a preview of what they have at their station so that when the participants want to come through, they know where to orient. So here's Kyle.
How you guys doing? Happy to be here today, happy to support. What we have here today, I've got Eddie here and Mason with Stryker as well. So what we currently brought is our Q guidance platform. So this was FDA cleared this summer. It's our next generation and what we like to call our guidance platform, and not specifically just for navigation. So currently there are major improvements to this system. The big one being the camera to our system. So this is our proprietary camera. We don't use any third-party cameras here. And the refresh rates are the biggest points of emphasis on our camera, and just how smooth and the lack of lag that you would experience whenever you're using this here. To that point, the camera as well as the system has two computers that are built for forward-facing when we start to incorporate robotics and some other projects that we're currently working on. So this system currently only uses about 20% of its capacity because it's going to be a forward-facing system as we start to incorporate more technologies here in the future. So what we're seeing here is when Eddie's just playing with some stuff is just how smooth and the lack of lag that we notice on the system. We also, on this system, have auto segmentation features, and that's one of the big things which we would love for you guys to stop by a little bit later. We're going to pull up another scan where we have a patient's deformity scan where we could show some of those auto segmentation features on auto screw planning, which is incredibly useful for preoperative planning as well as surgical accuracy. But the base of our auto segmentation, which we work in conjunction with, is our Aero CT scanner. So we own the Aero CT scanner now, and that is fan beam diagnostic quality technology. And when you incorporate the Aero CT diagnostic quality imaging along with our navigation system here, you can get one spin, so one image all the way from the occiput down to the pelvis. And with that fan beam technology, just some of the best bony quality recognition that you can get. So with that, we are currently FDA cleared to do the auto segmentation for the lumbar and the thoracic, and we're close to getting the cervical and pelvis as well. So some of the auto segmentation features we'd be happy to show you guys here once we pull up our other scan here in a few minutes. But these are some of the technologies right now that are FDA cleared and marketed right now, and we're going to have a lot more cool stuff on this system coming out in the near future. Thank you, guys.
Okay, thank you, Kyle. We're going to move on to Brainlab system with LoopX and Circ, and here is Taylor.
Thank you so much, and thank you to Dr. Muminetti for the great talk and covering the Brainlab Robotics Suite. So here you see sort of our three main components of what we're calling the Brainlab Robotics Suite. The workhorse of our navigation system, of our navigation platforms is the curve navigation, along with the Circ robotic arm here, which you see mounted to the table, and then finally the LoopX mobile imaging robot. So the mobile imaging robot is both a 2D and a 3D closed loop system. That closed loop allows us to accomplish some main features that are unique, to this technology. We can control the source and the detector independently of one another, and so that allows us to actually bring the imaging to the patient no matter where they are inside the bore. So we're not going to be worried about getting in the iso center. If you're positioned laterally and up against the edge of the bed, we can actually bring the imaging and bring the source and the detector to the patient. As Dr. Muminetti mentioned, we can collimate down to as small as 3 by 3, so it's fantastic for your pediatric cases, and you can really focus that radiation beam to get a nice high quality image. And again, we can scale up to get the entire pelvis, and we can also stitch, laterally up to 60 centimeters as well. The robotic features of the system give the surgeon more control throughout the case. So with your navigated pointer, you can navigate to a specific trajectory that you'd like to see. The surgeon can then call the scanner into place, and it'll take that perfect oblique 2D shot wherever the surgeon may want it. So if you have a difficult pelvic inlet or outlet view that you'd like to see, the surgeon can actually direct the system to where they would like to take the image, and it'll do that for you. And then finally is the incorporation of the system with navigation. So any of the screw planning that you see here can actually be imported into the scanner itself. So if you wanted to do your post-op 2D shots without doing a post-op 3D. We can, again, import those screws into the scanner, and the scanner can line up and take perfect 2D shots along the way. Here on the system, you see our brand new Spine Planning 2.0, which will be out here in the spring. So we have this ability now to not only plan on your 3D data sets, but load up pre-op standing 2D x-rays, and we can give you your global alignment parameters as well. So you can plan your automatic screws from cervical to sacrum and to pelvis alongside your 2D data sets. And then finally here, our Circ robotic arm. So low profile, low footprint, bed rail mounted system. It'll mount onto any standard bed rail in the OR. As Dr. Muminetti mentioned, you can set this up to be both a passive and an active system. So it can be entirely surgeon controlled without any robotic automation as well, or you can put the robotic alignment module here on the end. You as the surgeon would do the gross alignment with the system, get it close into place to your planned screw, and then it will do the fine tuning for you. So these three components combined make up what we like to call our Brainlab robotic suite. So again, thank you to SSF for having us. It's always a pleasure being part of this course.
Taylor. Okay, here we go with Dr. Larson and 7D.
Hi, I'm going to hand it off to Bo, but we just re-registered the same level, and I'm going to, again, got the same kind of accuracy on it, having moved everything. We'll hand it off to Bo for a moment here.
Yeah, so one of the probably big differences between this technology and other ones in the room are just how it looks. So inside of our surgical light, and it is certified as a major surgical luminaire, so you can use it as your primary light source. If you look inside there are actually several banks of cameras. And those banks of cameras are what allow us to create those instantaneous three-dimensional images of the patient's anatomy. And by having all of our cameras in the light itself, the surgeon maintains sterile control of the entire system throughout the procedure. With the boom arm as well, we have almost 7 feet. That allows you to be very nimble in your OR. Maybe you have a large OR, small OR, but you can put the base of the unit at the foot of the table, the head of the table, the side of the table, leaving up all the space in the operating room. And as you also see around our surgical field, we have nothing cluttering it up. Because our cameras are up top, our line of sight is also exquisite, where you can have everyone crowd in around the table, but you don't lose any tracking aspects of the tool. As we look on the screens, one thing that is pretty neat, you can see, so here's the 3D flash image that we just took, over 1 million data points, that creates the full volumetric scan of that patient's anatomy. On the left-hand side, we're doing true segmental registration. So we told it, in this case, just to focus on L4. It automatically extracted L4 without the need to segment, and every single one of those green dots has been intelligently selected to exist in the optical flash image, and its correlate point has been found in the preoperative CT. And here we have a little demo just to show you where it's doing a search feature. It'll play back very quickly, where it's actually going through thousands and tens of thousands of different fitting functions to make sure that L4 actually is the level that you're looking for. We'll accept this, and from this stage, you control everything as we saw in the demo before. We see some pre-planning screws there. You have your views. It's all customizable as well to your surgeon profile. You can change it into different visualizations, change this to a coronal view, see all of your screws, and then you're off to the races to do the navigation. Thanks very much.
Thank you. Awesome. Okay, moving right along to Medtronic, here's Dominic.
This is our Mazor X with Stealth Edition. This is our robotics guidance platform. Like Dr. Pham demoed for us earlier today. It is fixated to the bed, fixated to the patient. So 2 points of fixation allows for extreme rigidity, very accurate. There is the ability to use a pre-op CT, planning before the surgery, or an intra-op 3D spin with our O-arm that allows for, again, a quick planning process right after the spin, setting all of your trajectories, being shown today in the single position. So it offers a ton. In full prone, single position, and yeah, that's about it.
Okay, and second to last is Globus. Here we have
All right, yeah, my name is Mike Kaiser. I'm one of the regional managers with Globus, and thank you for having us here at the SSF, Dr. Drazen. Here we have our Excelsius GPS platform. It's a very stable system that's been out for 5 years, give or take, and one of the cornerstones of our system is that it's designed to be very adaptable, very flexible. You can see the system's not mounted to the table or the patient in any way. It's something that we can actually track in space, the end of our robotic arm, we call that the end effector. And it is one of the most accurate systems on the market for any type of navigation within surgery. Something else that's very unique is that we can work from the entire spine. So we do from cervical all the way down to the pelvis. We can work with multiple different types of workflows, so we try to be adaptable to the surgeon's needs, that being a preoperative CT workflow. We could also do an intraoperative workflow, along with something that's a little unique to us is doing just with fluoro. So in our case, if there was a situation where you didn't have a CT, we could actually still navigate and perform robotic surgery for your patient's needs. So Dr. Minista is here, and we could do a quick little demonstration if you don't mind going to the navigate page, sir. You can see here we've been set up for the thoracic space. We can just select the level that we would like to go to, a quick touch of the pedal, and you can see the system actually moving in space, tracking to the patient. And as you see it goes yellow, that means we're on trajectory. We could actually instrument at this point as well. Once we get to green, we're at the optimum height to instrument along with the depth of our products here. And we have the capability of doing freehand as well. So our platform is designed to be dual purpose. We have a power system that we're putting together real quick. But you could actually do this freehand. You could do it with the robotic arm. And as Jason comes around, you can see we are drilling down. This is a side cutting drill. We also have a high-speed powered drill that will get through the cortical. A lot of times that is used more often in the lumbar space. As you can see, if you'd like in your workflow, you can do a tap. We do have a robotic screw available as well, where you could actually just go from high-speed burr straight to the screw. And then we're going to just do a quick demonstration of putting in the screw. Oh. Where's that scrub tech when you need him, Dr. Minista? Fire, yeah. There we go. All right. Now we're putting the screw down. There we go. We can also put the screw in under power. That's always an option under our system as well. And then as you see, right when we got to the depth within 1.5 millimeters, you get the check mark. There you go. That's a quick demonstration on our screw technology. Thank you.
All right, final company is a little company that could, Ruthless Spine.
Thank you. How are you? Thank you for the SSF invitation, and we're very pleased to present our product here. This is the RJB. This is the entire navigation system. An RJB module and Android tablets. Every time I hear about a surgical misadventure or excursion to a foreign land using navigation, or I hear Dr. Terrence Kim talk about the coordination required to get the nav system working with all of his people in the OR, it sounds like the Rockettes Christmas show. I work at a small hospital, a small community hospital. One day I'm in the OR and I realize that my community hospital will never give me navigation. So I thought, what is the minimum I need to accurately put in screws and get rid of everything else? There is enough computing power in all of the rest of it to create an AI that will destroy the world. This module slips into these easily made gear shift handles, disposable gear shift handles if you so like, and it tells me the trajectory, if you would be so kind as to look, of the shaft of the instrument. It tells me the axial angle, which is this, and it tells me the sagittal angle, which is this. There is 100% reduction of pre-op and intra-op CT radiation because there is no CT radiation. I only use MRIs. And The way I do it is I have my PA look at the axial images, as you can see over here, and draw angles using free, cheap protractor apps on my Google phone or the PACS software that is included. She tells me and writes it on a piece of paper every angle that I'm going to instrument that day. And then I go into the OR, and for example, this is 19 degrees. So what I do is I go here and I change up my axial angle, 19 degrees. And that guides my screw in the axial plane. The sagittal plane, I can do live with a cross-table fluoro. And therefore, no matter how much PSO, T-lift, reduction, whatever I do, the sagittal angle can change between a supine CT scan and a prone patient. And then you do more stuff to the patient, you decompress, everything else will change that sagittal angle and the orientation. However, the axial angle never changes because that's a bony orientation. So therefore, no matter what I've done, once I've done whatever I'm going to do, a live fluoro shot will tell me the exact sagittal angle, and then I match it to whatever sagittal angle I see on the live fluoro shot. Then I yell at my rep, hold. He holds, and that will hold the number that I need. I do not have a PA who I feel is ready to put in pedicle screws. I do not have residents. I do not have fellows. I put in every screw myself. So I put in my screw on this side, and then I reach over to the other side for without switching sides, and then I match the angle. 14 and 6. And then I drive it home on the other side. So I'm able to put in 2 screws with a single fluoro, shoot, shoot, move to the next level, shoot, shoot, move to the next level. I've put in 10 screws in 8 minutes doing this. You can do this open. I don't do MIS surgery typically, very rarely. However, MIS is very easy with this system as well. How does this register to the spine? This module registers to gravity. I take an AP fluoro shot of the spine prone or in the lateral position. I have done this with lateral lumbar interbody fusion cages just to see it. And then once I am perfectly aligned on an AP with the spinous process bisecting the pedicles, the spine is aligned to gravity, the module is aligned to gravity. Therefore, the transitive property of spine surgery says that this is aligned to the spine. I don't have to drill anything into the ASIS. I don't have to clamp anything to the spinous processes. I don't have to do intraoperative or preoperative CT scans. This does not record any individual patient data. There is nothing to discover at a later time. This is live, okay? And then, so that essentially is the entire thing. I have been asked, oh, what if there's a rotational scoliosis component? We have a correction for that. It's an offset function. It's a more advanced technique. Your rep may have to do math, which was a big burden, but yes, your rep may have to do math, but it's very easy to do. So this, every time your nav does something that you don't want to, the software update that costs $60,000 a year to your hospital somehow doesn't interface with the PACS system from an outside hospital and your CT scan doesn't load up. Or Dr. Kim's NASCAR driver of a radiology tech busts his nav system. Or someone has forgotten to plug in the O-arm and then it won't move. It's a 5,000-pound paperweight. All of these things have happened. When that happens, this is a consumable. There is no capital cost to the hospital. And so tell your hospital, put it on the shelf. If the nav poops the bed, they can whip this out. There's a barcode on the back. All you do is you take your camera on your app, it reads the barcode, and you're up and going in 10 seconds. I have put these in here. I have smacked the heck out of it with a mallet. Still works. If somehow it doesn't work, throw it away, open up another one, and you're back in the game in 10 seconds. If your nav is out, then you're back in the game in 10 seconds.
Okay, thanks so much. We're now welcome to enjoy the technology, and thanks everybody for coming.